So iron deficiency anemia is a very common and prevalent condition in about 5% of the US population. But many people who have it actually don't know they have it because they never see any blood loss. And so what they actually need is diagnostic testing with endoscopy and colonoscopy. And we are finding that less than half of patients are even getting that ordered by their clinicians. So our program aimed to close the gaps in diagnostic evaluation of iron deficiency anemia by helping clinicians improve their ordering practices and also giving patients the resources that they need to do that through educational materials as well as patient navigation services. So anemia is often a very early but often overlooked indicator of more serious disease. You really want to be able to identify the things that are leading to it first. And so we need to see this as an early warning sign and diagnose it accordingly. First, we built a clinician-directed intervention, which is integrated into the electronic health record, and that nudges clinicians to order appropriate testing, identifies patients who are eligible, and gets the testing ordered. So in our trial, we have proposed to stratify our intervention by the percentage of Black populations in each clinic setting. We found that clinicians were less likely to order the exact same tests when the patient in front of them is Black, and also even once a test is ordered, Black patients were less likely to complete it. And we actually have 49.7% of our patients in this area are self-identify as Black. So we do have a pretty diverse group, and we're hoping that that can allow us to more comprehensively test intervention effectiveness. But we also recognize that now we need a patient-directed intervention. And so we developed new educational materials with help from the American Gastroenterological Association, and we did a focus group in order to refine those materials and help educate patients better on the need for testing. The national guideline that we based our work off of needed to be adapted to our institutional and system level environment. And what we realized is that there's so much variation in our thresholds to refer to different specialties or to get patients different access to care. And so we actually take the clinician decision support tool and adapt it to an institutional pathway. So both of our interventions were using principles of behavioral economics to better understand all of the barriers in closing this evidence to practice gap. And we recognize that there are so many heuristics or biases that go into it, like the status quo bias or, decision fatigue that patients and physicians both have. And by grouping orders together, minimizing the work for both clinicians and patients to do, we were able to develop these two interventions. We developed both the electronic health record intervention and the patient educational material. They were both pilot tested, refined, and ready for prime time. Now our goal is to test the effectiveness of both of these two interventions in a trial. I'm hoping that we can show that these interventions can be utilized in diagnostic medicine and then expand them in other conditions.